Number three, very important, we look for fetal MCA. Okay. So each of this, that is when you want to look at umbilical artery, you see the waveform and you see the various parameters. So you calculate various parameters like PI, RI, etc. Similarly, when you look at the uterine artery, you see the waveform and you see the various parameters. Similarly, when it comes to MCA, you see the waveform, you see the PSV, you see various parameters. Okay. Now, so there are two important things, actually three important aspects when a vessel is to be examined. So suppose this is a vessel. So when it comes to Doppler examination, the three important things of examining patient in Doppler are: number one is the technique, that is how and where are you going to place your cursor so that you get the best waveform. Next you get is the waveform. Okay, so first is the technique, second is what you get, the waveform. Now once you obtain the waveform, the third important thing is interpreting this waveform, that is what type of waves this is, and you calculate few parameters out of this waveform based on the PSV, based on EDV. So I shall be discussing what PSV is, what EDV is, and based on this we calculate parameters like RI, PI, etc. I will also be telling you what of these are angle dependent, what of these are non-angle dependent, everything. So don't be in a jargon, we'll be making everything very simple. Okay, let's start with very basics, and in between I'll be showing you videos of how the actual technique of examining these three vessels, that is the umbilical artery, the uterine artery and fetal MCA, is to be done. And at the same time I'll be also discussing on various important precautions that you have to take so that you do not get false positive Doppler. Okay, so let's start with, so whenever you start studying ultrasound or whenever you start studying any science, any medical science as a whole, you should always start with anatomy. Okay, so fundamental anatomy of that of the fetus is that you know that there is placenta. This placenta is attached to the fetus via umbilical cord, and this umbilical cord has got three main vessels. It has got three main vessels. So there is a single umbilical vein which is shown red in color, and there are two umbilical arteries. So there are three vessels inside the umbilical cord. Okay, this is very important. So now, why is this thing important? Because when you would be seeing the umbilical cord, I'll also show you in the videos that if you see it from a longitudinal view like this, long section, profile view, so you would get to look umbilical cord which looks like this. It would look like a cord like this. But if you look it along the section, along the axial section, if I look the umbilical cord at this level, I cut like this, then the image which you get would look like this. So you will get there are two umbilical artery, one umbilical vein, okay, which are there inside. So this is called Mickey Mouse pattern. This is called Mickey Mouse appearance. I'll also show you in the video how Mickey Mouse appearance looks like. Okay. Now, moreover, when it comes to the umbilical vein, it is the vein which carries the fresh blood from mother towards the fetus, and the umbilical artery is reverse. So umbilical artery carries the impure blood from the fetus towards the mother. So what the artery which we are examining here in umbilical cord Doppler is the umbilical artery. Very important, umbilical artery. So any of the two umbilical artery will do. And most importantly, there are changes which occur in umbilical vein also, but those changes are seen in much later phase. So initial changes you see it in umbilical artery as compared to umbilical vein, and as a result the Doppler of umbilical artery is more significant than umbilical vein. Okay. Now, also if you see, the waveform of artery is different from that of waveform of vein. Now, some of the few basic techniques which you must remember when you are doing an umbilical artery Doppler, and then we'll be showing the videos so that it becomes clear. So, number one is you have to locate the umbilical artery. So, to locate the umbilical artery, imagine that this is uterus. This is uterus. So, there would be a placenta inside. So, this would be the myometrium, and then there will be placento-myometrial junction. This is placento-myometrial junction. This is placenta. Okay. Now, this placenta would be attached to the fetus via umbilical cord. Right? This is what would be there. So, now there are three important segments of the umbilical artery. One which is near the placenta. So, this is called as umbilical artery near the placental end. Number two is one which is near the fetus. This is the placental artery near the fetal end. So, this is the umbilical artery which is there at the fetal end. Now, here you have got, this is in between. So, this is called free end of the cord, the free loops. Now, why is this important? The earliest changes of umbilical artery, I want you all to tell, where would you get the earliest changes of the IUGR? Whether at the placental end, at the free end, or at the fetal end? Where do you expect the IUGR changes to occur earliest out of this three? So yes, I've got few of the answers at the placenta. So Farheen has said placental end. Some of you are saying fetal end. Okay. So the correct answer to this is you start seeing changes earlier at the placental end, placental end, placental end. Okay, placental end. Okay. Good, 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 good. So most of you are going correctly. Yes, you see the changes at placental end, correct? But do we prefer placental end? Do we prefer placental end? Answer is no. We do not prefer placental end. So although the changes are seen early towards the ends, but we do not prefer them. We always prefer free loop. Very important. So why do we prefer free loop instead of the placental or fetal end? Because these are those areas which gets easily manipulated. So even if some amount of pressure is applied by the fetal part, or you increase the pressure from your end side, that is, instead of giving slight minimal pressure, if suppose you press the probe hard, then you might get all those umbilical artery changes like absent end diastolic flow, reversal of end diastolic flow, just by pressing those arteries. So when you are doing umbilical artery Doppler, you have to be very careful that the loop of cord which you select should ideally be free loop. Free floating loop is always ideal when it comes to umbilical artery Doppler. Now, why? Because there is no extra additional stress over it. There is no compression force over it. So when you apply probe over this, you always try to be very gentle. Your probe has to be very gentle. This is not just true for umbilical artery. Same when you would be taking fetal MCA Doppler. Again, when you do MCA Doppler, your probe has to be very gentle. By now, all of you are aware that the probe which we shall be using for this is convex probe or abdominal probe, right? Always discuss this when I start the basics. Now, convex and abdominal probe. Why would you prefer convex and abdominal probe? Because here we want more depth. So, wherever you want more depth, you would be preferring the convex probe or abdominal probe. Now, I ask you a simple question. Suppose you want to look at this junction of placenta and myometrium, then which is the best probe? Is it convex probe or linear probe? So the answer to this is the convex probe better for placenta myometrial junction or a linear probe better for placenta myometrial junction? So it correct, very good. The correct answer is linear probe. Linear probe is always best. So I'm very happy with the audience. They are very attentive. Now, why you have to so yeah, few of the answers are convex probe. So let me correct the basics here. So what is the basics? Convex probe versus linear probe. When it comes to convex probe, or which is also called as curvilinear probe, which looks like this, the main curvilinear probe, this is the probe which has got less frequency but high penetration power. So what if the penetration power is more? What is the advantage? It can go through more depths. It can go through more depths. So yes, convex for deeper structure and linear for pediatrics. Linear for not just pediatrics, but linear for any superficial structure. Suppose you want to look something which is superficial, or not just superficial, something which you want to look with more resolution, better resolution. Like for example, you're looking at spleen of a patient. Okay. And you want to see if there are small micro abscesses within the spleen. Then the probe which you would prefer is linear probe. Okay. Same, suppose you want to look at small changes within the placenta, or sometimes you might want to look for smaller anomalies in fetus which is just 15 weeks or 16 weeks. So in those cases, again, linear probe is better. Now, with this in our brain, free loop is the best one for looking umbilical artery Doppler. We have seen that. Now, let's move ahead and see the basic Doppler tracings which we get when it comes to umbilical artery. So, the basic Doppler tracing which we get when we look for umbilical artery looks like this. So, if this is the umbilical artery, suppose you place your cursor within this and you take a tracing of the umbilical artery, so you would be getting this type of waveform. So now, what is this waveform? Let's make it very simple. Okay. When it comes to Doppler, everyone becomes afraid what this is. Let us make very simple. In our basic school days, we used to have those graphs where there used to be x-axis and there used to be y-axis, right? Now, our science teacher used to always tell us what is plotted always on x-axis. It is the time. It is the time which is always there on x-axis. Okay. And what is plotted on y-axis? It is the velocity which is plotted on y-axis. Okay. So this graph is graph of velocity against time. Simple. Let us simplify it. Okay. So now what you are seeing here, this is nothing but the flow of blood. So this is the range of velocities with which the blood is flowing within the vessel. Okay. So there is a vessel through which the blood is flowing, and this blood is flowing through a range of velocities. And this is that range of velocity which you are getting. Okay. This is number one. This is number one concept which you have to remember, that one waveform represents the range of velocity in which the blood is flowing in a particular vessel. Okay. Now, when it comes to this peak, so this looks like a hillock. When you see this peak, this is the peak systolic velocity. That is the peak velocity during systole. That's why it's called peak systolic velocity. And now, this what you are seeing, where the hillock ends, what is this point called? Yes, what is this point called? This point is called as, very good, this point is called EDV. Very good. So few of you have correctly answered it. Yes, Dr. Rashmi. Good. So this is EDV. What is EDV? End diastolic volume. So that is when the heart reaches diastole. At that point, what the amount of velocity is present in the flowing blood This is the diastolic velocity or end diastolic velocity. Okay, got it? Now this is true for any Doppler tracing. Suppose you do for MCV Doppler, MCA Doppler, or uterine artery Doppler, or you do limb Dopplers, these parameters would remain same. Okay, now few important questions which I would love to ask you here is that now uterus is a very vital organ when it becomes pregnant. Okay, when it becomes pregnant, uterus becomes very important. Why? Important in the sense that the blood flow to the uterus has to be there during systole as well as during diastole. What if the blood flow to the fetus is not there during diastole? That won't do, right? So uterus has to be supplied during systole as well as during diastole. Okay, but some organs, like in case of limbs, you would get like lower limbs. So the vessels of lower limb, like common femoral artery, if you take the waveform, you would get like this. You get three waves. So there is a negative flow during diastole. So positive flow during systole, and then you have a negative flow, and then there is a recoil flow, positive flow. So this is called triphasic waveform. Three waves. One wave, two wave, second wave is negative, and third wave is positive. So this is called triphasic waveform. So triphasic waveform are seen in those organs which are vitally less important. For example, upper limb, lower limb. So they are less important when it comes to brain, when it comes to developing fetus. So in all this organ will be having very good. So uterine artery would have triphasic waveform, Dr. Rashmi, initially when it would be non-pregnant. But when uterus becomes pregnant, the flow of uterus becomes like this, right? So later, when the pregnant uterus would have a monophasic flow and not triphasic flow. Okay. Similarly, umbilical artery has got just a single wave. Just see this one wave. There is no negative wave which is going. So that means the normal umbilical artery flow is monophasic. Monophasic. Very, very important. Monophasic. Okay. So this is the concept of monophasic. So just to show you, how would a biphasic waveform look like? So I'll draw here a biphasic waveform for you. Wait a minute. What we'll do is we'll rub this for you. So now I'll draw a few waveforms for you so that it becomes clear. So I'll use this to draw waveforms. So let's see, number one waveform. So number one, this is waveform type 1. Number 2 waveform. This is number 2. Number 3 waveform. So now if you look at these three types of waveform, okay, let's see what these things are. So number one, yes, Dr. Rashmi has asked me a question, so I'll also come to that question once we discuss this. So number one, if you see this waveform, what type of waveform is this? Just single wave, right? There is no negative wave which is going. So this is monophasic waveform, right? Now what is this? The second type of wave. So if you look carefully at this wave, you see that there is one positive wave which is there and there is one negative wave which is there. So this is a biphasic waveform, biphasic pattern. Okay. And number three, if you see this waveform where you have this is monophasic. So this is a positive wave, one wave. This is another wave, and this is a third wave which comes on. So these are three phases. So this is called triphasic. There is a quadriphasic pattern also, where you have got four waves. Okay, so our body has got these patterns of waveform: monophasic, biphasic, triphasic, quadriphasic. Now for some organs monophasic is normal. For some organs monophasic becomes abnormal. Okay, similarly for some organs triphasic is normal, and for some organs triphasic becomes abnormal. Like Dr. Rashmi asked me a question, right? For example, let me give you an example so that it becomes very clear for you. For example, when it comes to brain, the vessels which supply brain is internal carotid artery. What do you think? What should be the waveform of ICA? Should it be monophasic? Should it be biphasic? Or should it be triphasic? Yes, interesting. Very good, Dr. Veena. So you got the concept very nicely, that whenever the blood supply to an organ has to be more, the organ is very vital, it always gets monophasic flow. So the blood flow of ICA is monophasic. Okay. Now, suppose if you see triphasic waveform which is going in the brain, is it normal? Answer is it's abnormal. Okay. So so similarly, when it comes to uterus, this is uterus. Here lies the placenta. Now, why is this thing important? It will clear Dr. Rashmi's doubt. See, here there is placenta. And suppose you are taking waveform from the uterine artery which is located on the right side here. Now, this placenta would be predominantly supplied by this area, the right side area. So, I would expect that this uterine artery should always show monophasic flow. And suppose you don't get monophasic flow in this side, or you get notching on the side where the placenta is not there, then it is acceptable. Okay. So if you get notching on the side where the placenta is not there, then it is acceptable. But if the placenta is like this, is there on both the sides, then we always expect that both of this should show monophasic flow. Dr. Dipti has asked me to repeat this concept. Okay, so I'll repeat this for you. See, the concept is, many a times when you look at the, imagine this is uterus. This is the uterus. Okay. Now, when you examine for uterine artery, so there are two separate Doppler. One is umbilical artery Doppler. For umbilical artery, you have to look inside the uterus. Uterine artery, where would uterine artery be located? They will be located outside the uterus. They will be located here, outside the uterus. And if you see the waveform of uterine artery, sometimes you find that on one side the waveform is normal, and on one side the waveform becomes abnormal. Okay. So on the side, so how do you determine which one is normal and which one is abnormal? So you look where the placenta is. So if the placenta is on the side where there is normal Doppler study, then nothing to worry. But if the placenta is located on the side where you have abnormal Doppler waveform, then you have to worry. Okay. So these are simple concepts. Now let's move ahead with this. So these are few important things. This is the Doppler tracing. When you trace a Doppler, your screen should have at least 6 waves, not more than that. Because if you take more than that, you see that the quality of waveform in the measurement goes down. Now, this is the scale which you have. So what you're seeing here, the 180, 120, 60, these are the scale. Now, what is the unit of this? Again, unit is very important. You know that velocity, we had studied in basic physics, velocity is distance by time. So here, this distance is measured here in centimeters and time here is in seconds. So the unit of this is centimeter per second. So this unit is written here, centimeter per second. And this is how the time goes on. So as the time goes on, you see that the new waveforms would be generated. Okay. And so whatever measurements you take along this, that would be giving you the velocities. Okay. Now this is the peak systolic velocity and this is the end diastolic velocity. Okay. Now there are three, again, which waveform would you use for measurement? So you would prefer those waveforms where at least you find that there are three normal consecutive waves. So you should have three normal consecutive waves. Then you select the best waveform out of this for measurement. For example, if you select this waveform, what is going to happen? Look here, the PSV and the PSV. So you might underestimate the PSV. Okay. Similarly, look here, the peak is not well seen. So such waveforms are not to be selected when it comes to calculation of various Doppler parameters, fundamentals. Okay. Next, if you see your machines, ultrasound machines, you see that there are multiple ways to calculate the parameters like PI, RI, S by D ratio, etc. So one of this parameter is called automatic measurement, use automatic trace. So suppose if you take an automatic trace, so the automatic trace goes on like this. It would trace this, then it might trace this waveform, then it might trace this waveform like this, then it traces three correct waveforms. Although these three waveforms are correct, but what is going to happen? Our readings would be abnormal. Our readings will not be correct. If you take automatic trace, and automatic trace includes these waveforms and such readings are recorded, then your PI and RI, what comes on would be abnormal. Okay. So it is better to trace manually. So there is always an option, trace manually for calculation of PI. So you go for that option, that is always the best option. So you have to manually trace this. And once you trace this complete waveform, you get the readings of PI, RI, S by D automatically. The machine calculates automatically. There is one third option where you can just select three waves which are best. You can put your cursor in between and the readings are given. So that is a third wave. Okay. So Zareen Parveen is asking what are PI and RI. So I'll also come to that concepts. Zareen, no need to worry. Okay. First basic, have you understood all that these are waveforms of vessels? We talked about what is monophasic, what is diphasic, what is triphasic. I've told you that when the organ is very vitally important, you would be having monophasic flow. When it is vitally less important, you would get triphasic flow. Okay. Now, suppose you are doing a limb Doppler, Doppler of lower limb, and in lower limb, what is the waveform which you expect in lower limb? Triphasic waveform. But suppose in lower limb, you start getting waveform which is like this, monophasic waveform, then that is abnormal. Okay, then that is abnormal. So if you start getting monophasic waveform in lower limb, then it is definitely abnormal. So monophasic waveform in lower limb is seen in peripheral vascular disease, PVD, or when there is thrombus proximally. So then you start getting monophasic, because at that time when there is thrombus, that limb also becomes very important for the body, and body starts giving collaterals, and hence you would be having a monophasic flow. Another important thing which you need to remember about when you get monophasic flow and when you get triphasic flow is when the resistance is less. When the resistance is less, you get monophasic flow. And when the resistance to the vessel increase, the monophasic flow changes to biphasic, then changes to triphasic. So peripheral vascular resistance. So in limb vessels, there is more peripheral vascular resistance, and as a result, the waveform is triphasic. Now, where else do you apply this concept? We apply this concept when it comes to in those patients with IUGR, patients with eclampsia, pre-eclampsia. What happens is the resistance in the vessels, the umbilical artery goes on increasing. And when the resistance goes on increasing, what is going to happen? Instead of getting all this monophasic flow, you start getting what? Decrease end diastolic flow. And then ultimately you start getting absent end diastolic flow. And ultimately then you start getting reversal of end diastolic flow. So in short, what has happened? Reversal means what? There is a reverse wave during diastole. So how many waves are there? One wave during systole and second wave during diastole where there is reversal. So when the resistance increases, you would find that the monophasic flow turns into a biphasic flow even in umbilical artery. So when it becomes biphasic flow, it denotes what? There is reversal in and during diastole, and that means that this is abnormal. Okay. Chalo, let's move ahead with this. So umbilical artery, we have seen that. Visualize the cord, select a free loop of cord, which is very important. Now we'll also see the Doppler indices. Few of you were asking me beautiful questions that what PI is, what RI is. So we'll also see that the impedance is higher at the fetal end and a free loop is always better. Okay. Now see, this is the color image of the free loop of umbilical cord, which demonstrates beautifully two arteries and one vein. Okay. So now you can see here, this what you are seeing is the longitudinal view. What we saw is the longe view of the umbilical cord. And this what you are seeing here, this is the axial view or transverse cut. So it's like the hand, if I cut like this, you would be getting a longitudinal view. If I cut it like this, you'll be getting a axial view. Okay. So now this is what we saw about. Now look here, what other important things? Yes, very good. So Zainab has pointed out very correctly that this appearance, what you are seeing, I'll use a different color for you. This appearance, what you are seeing here, 1, 2, 3. This is the Mickey Mouse appearance, what I talked about. Okay. Now, another important thing which I want you all to focus is that whenever you are doing Doppler, you should always look at few things like this. See here, this, what is this? This is the uterine myometrium. This is the uterine myometrium. Now look here, this is placenta. So this junction is the myometrio-placental junction. Okay. Now, so see how clearly you can see that there is myometrio-placental junction which is maintained. Okay. If this is not maintained, that means that is adherent placenta. That's a separate topic. We have talked about that topic in details on our website. Now, see here this placenta. So this is placental tissue. Okay. And you would be having a cord which would be attached to the placenta. Now, few other important things which I want you all to focus is, what is this? This is called color box. This is called color box. Okay. Now, many of the times, what happens is people put a large color box and they try to see things. So always remember, this color box size has to be as small as possible. As small as possible. So if you put this color box size to as small as possible, you would get beautiful images. Okay. The Doppler colors would be beautiful. Now, let's see the waveforms. Initially, at around 10 weeks, the waveform is like this. So you see that during diastole, there is no flow during 10 weeks of gestation. Why? Because the fetus is still small. It does well with low blood supply. But as fetus grows to 20 weeks, you see that the diastolic flow increases. And as it grows further, the diastolic flow is there. So the Doppler, which is usually done in the third trimester, after 28 weeks of gestation, you would always find that there should always be end diastolic flow. So after 28 weeks, you should not get absent end diastolic flow because that indicates this is abnormal. Okay. Now you have got various parameters. So one is called PI, second is called RI. So both of this, what are this? So these are parameters which are calculated based on PSV and EDV. PSV and EDV. So let us make it very simple so that it becomes easy for you to understand. See, just like when we read physics in our basic school days. What did you have? That there is a conductor, and through this conductor there is current which is passing. Okay, there is current which is passing, and when the current is passing, it is electrons which are flowing inside in the opposite direction. When these electrons flow, there is a resistance to this, and the more resistance, lesser would be the current. More the resistance, lesser would be the current. Same here. Okay, so more the resistance, lesser would be the blood flow. Okay, so if I say Ri increases, it means resistance increases, so the blood flow would decrease. Okay, so now when I say that Pi of the uterine artery increases, what does it mean? Pi Ri increase means resistance increase, and if resistance increases, it means that the blood flow to the uterus is going down, the blood flow to the fetus is going down. Okay, now let's go ahead with this. So we have seen in brief about umbilical artery waveforms. Before we come to this umbilical artery waveforms, what I want you all to see is few videos. So now look here. This is beautifully showing the umbilical cord. So can you see this? This is the umbilical cord. Okay. Now look here. So you can see the longitudinal section of the umbilical cord, as well as I've shown you at places. This is the Mickey Mouse which is seen. So you can see that there are three vessels within the umbilical cord. Okay. Now this is the color box which has been kept. So can you see this pulsatile? So these two vessels are pulsatile. The blue in color, they are pulsatile. They are pulsating. Okay. So now, just now, one of the student had asked me a question: which is the Doppler will you use? Will you use a color Doppler or will you use a pulse wave Doppler? So it's better to use color Doppler, right? Use color Doppler. So now we have put color Doppler here and we have obtained the trace. So this trace is velocity against time. See now, this is how we measure the PSV. Are you able to see how PSV is measured? So I have put my pointer just above the waveform and you are able to see that the PSV readings are obtained. Okay. Now see here, this is the Mickey Mouse. This is the cord in launch. Now this is the color flow within the cord. Now this is the limb which has come up. So now this is very important. Now see here, initially when we were examining, with ultrasound, this loop of cord was very good. Why? Because it was a free loop. But now what has happened? The fetal part has come in between. So this might interfere with the waveform pattern and measurement. So you should wait till the loop becomes free. See now again the fetus has moved its part. The loop becomes free. And now I want to show you this waveform. So can you identify what waveform is this? This is monophasic waveform. Okay, this is the monophasic waveform. Yeah, this is the monophasic. Now look here again. Can't see the video. Can't see the video. Can't see the video. Can't see the video. 1 minute. Video is not seen. Okay, sorry for that. Wait. Sultan sir, can the video?
Yes, sir. Now the video is visible. You can play.
Okay, okay. I'm really sorry. I was not aware that the video is not seen. Yeah. Now, yeah. So see here, you can beautifully see the umbilical cord. This is the umbilical cord in transverse view. This is the Mickey Mouse, what you are able to see. Now this is in longitudinal section. You can see here, this is the color flow where we are, which we have applied. Now what I want you all is to look at those vessels which are seen blue here and those vessels which are seen red here. So look carefully over the blue vessels. Blue vessels are coming and going, coming and going. They are pulsating. Look here, the blue is pulsating and the red is still. So the one, if you put I have put the waveform in the pulsating vessels. So see the waveform which I have obtained. This is the monophasic waveform. This is the arterial waveform which is obtained. Okay. So now look carefully and we take the measurement. So this is how we measure the PSV. I have kept the cursor over the highest peak and one cursor over EDV. So if you keep this, the machine itself will calculate the PSV, EDV, S by D ratio, RI and PI. Okay. And these things are easily obtained. So now look here again. This is the uterine wall. This is the umbilical cord. You can clearly see this pulsating cord. Now look here at this. This is the part which I was talking about. So till now, the fetal part was freely moved. The fetal cord was free. The part which we were examining was not covered by the fetal part. It was a free loop of cord. Now what has happened here? The fetal part has come in between, right? So here we would wait till this part moves away. So now this part moves away. And now say, look here, what is this waveform? This is the waveform, venous waveform. So this is the waveform of the umbilical vein. So umbilical vein waveform is like this. Sometimes the cursor might go somewhere in the arteries and you can get this type of pattern, which is mixed pattern. Okay. So now look here, this pulsatile is the umbilical artery. This non-pulsatile red one is the umbilical vein. And see, this is what I wanted to show you, that if the cursor is in between, you get such mixed pattern. Okay, you get this mixed pattern. So now, see, look carefully. So this is how you put cursor inside. So this is the free loop of cord. So now what I want to show you here, very important, see here. Now this was the cord which was pulsating. Now the waveform which you have got initially was a reverse wave. Look here. Yeah. So it was downward, downward. So this can be changed. So there is an invert key which is present on your keyboard, or up and down key, U/D. So if you press on that, the waveform becomes upright. So now this is a very good waveform which you have got. Now one more important thing here, this is still crowded. Okay, although it is good, this is still crowded. The measurements would go PSV to EDV like this, and as you put your cursors over PSV and EDV, the machines would automatically calculate the various values. Okay, so now this is again further what I've done is I've increased the depth, and see how beautiful the waveform has become, more beautiful. Okay, so I'll also talk few small things when the video gets done. See now, if the scale becomes optimum, see the waveforms, how beautiful waveforms you get. Okay, so the scale has to be set to optimum. The depth has to be optimum. The color box has to be as small as possible, and your F sample gate should be 2/3 of the vessel size. I'll talk about that. Okay, so now we have finished this video. Sultan Ansari, my slides are visible, no?
Yes, sir. Yes, sir.
Are my slides visible?
Yes, yes.
Yeah. So the point which I was talking about is that if this is a vessel, if this is a vessel, then when you want to examine the vessel, you put a color box like this along the vessel. And the next important thing is you have to put a sample gate in this. So this sample gate has to be two-third of the size of the vessel. You can change the width of this. Okay. So if you put it too low, again you would get false reading. If you put it too large, again you would get false readings. Okay. So you should put it such that it is present in the center of the vessel, which you want to measure, and it should cover two-third of the diameter of the vessel. Okay, this is ideally placing the sample gate. Okay, moreover, these parameters what you see, that is S by D ratio, PI, RI, these three are non-angle dependent. They are not dependent on angle. So that is the advantage. So what if they are non-angle dependent? So if the vessel is like this, and if you do not orient your velocity along the vessel, still then the readings what you get, PI, RI, are accurate. Okay, these are not angle dependent. Now, but when it comes to MCA PSV, that is peak systolic velocity of MCA. Now, very important, this is angle dependent. Okay, and that is the reason why when it comes to MCA PSV, we always say the angle has to be kept less than 20 degree. Okay, so that is where this is dependent on angle. Okay, PIR and angle independent. Now let's come to abnormal waveforms in umbilical artery, the low diastolic flow or high resistance waveform. Okay, so I already talked about that when the diastolic flow decreases, the resistance is increasing, and you would find that these indices. So, what are the indices? PIRI, they go above the 95th percentile. Okay, so they go above 95th percentile, and what you have is absent end diastolic flow, or sometimes you have reversal of end diastolic flow. So, above three types are indication of increasing resistance. So, what we are measuring is resistance. So this answers the question of the student who was asking, what does PI and RI indicate? They indicate what amount of resistance is there in the vessels. So if there is more resistance, it means less blood is flowing to the fetus. So indirectly, if less blood is flowing to the fetus, it means what is going less? Oxygen is going less to the fetus. It means what we are measuring is fetal hypoxia. So all these changes, what you get, the changes in the umbilical artery in the form of absent end diastolic flow or reversal of end diastolic flow are indicators of fetal hypoxia. Okay. Now, this is a beautiful image. You should always remember this in your brain when it comes to umbilical artery waveforms. So the first waveform which you are seeing here, I'll use a separate color so that this becomes good. So this is systole, this is diastole, PSV, EDV. Okay. Now, if you see here, during EDV, that is during diastole, there is a good amount of flow which is present. There is good amount of flow which is present, good amount of flow which is present. Okay. So this is the normal umbilical artery waveform. Now, as the resistance increases, when the PI rises to almost 30%, so PI is what? It's an indicator of resistance, simple. Pulsatility index. So basically, it's an index of how well pulsatile the vessels are. Okay. Or in short, if the PI increases, the resistance is increasing. Okay. So the villus vessels, if they are under perfused, you would find that the diastolic flow goes on getting down. See, this is getting down, this is getting down. So this is the initial indicator. So what would happen? So this is PSV, this is EDV. Okay. Now, if you see here, if you calculate S by D ratio, how do you calculate S by D ratio? PSV upon EDV. Machine itself calculates, but this is how we calculate it. PSV upon EDV. So I'll teach you basic things. What is S by D ratio? Let's make it very basic. It is PSV upon EDV. That is peak systolic velocity upon end diastolic velocity. Now, if you compare graph 1 with graph 2, what is changing? Is PSV changing or EDV changing? You will say clearly, it's very easy. PSV has remained the same. It is EDV which is changing. In graph 1, if you see, EDV is more. In graph 2, EDV has gone down. So now in S by D ratio, what is happening? PSV is remaining the same. So numerator is remaining the same. Denominator is decreasing. So basic max. If denominator decreases, the value of the fraction goes high. So that is why as the condition deteriorates, S by D ratio increases. Okay. So as the diastolic flow is going down, you will find that with time, the S by D ratio goes on getting higher and higher. Okay. Now a time comes when the resistance further increases, villus vessels are underperfused, and here you have absent end diastolic flow. Neha Khanam wants me to repeat this concept again. Okay. The concept of S by D. Okay. See, it's simple, Neha. S by D, that is systolic velocity upon diastolic velocity. So when you say S by D ratio, don't be afraid of that. S by D ratio is what? The systolic velocity divided by the diastolic velocity. Now, with systolic velocity, it is the peak systolic velocity, PSV, upon EDV and diastolic velocity. Okay. Now, this you got it. Now, if you see, compare graph 1 and graph 2, the PSV almost remains the same. It is the EDV which decreases in graph 2, right? So here the numerator is remaining the same. It is the denominator which is decreasing. That is, PSV is remaining the same. It is EDV which is decreasing with increased PI. So EDV decreases. So what would happen to the ratio? Ratio would increase because whatever is in denominator is inversely proportional to the ratio. Okay. So EDV decreases and S by D ratio goes on increasing. Okay. Now a time comes when this end diastolic flow is absent. Okay. And this indicates that 50% of the vessels are under perfused. And then time comes when this 70% of vessels are under perfused and you get reversal. So what is this waveform pattern? One wave, two waves. This is biphasic. So from monophasic, it went to biphasic. What happened during this? S by D ratio increased. What happened to PI? PI increased. What happened to RI? RI increased. Okay. So in short, resistance increased. Okay. So resistance went high and you find that the S by D ratio has also gone high and you see that the waveform is changing. So whenever you are interpreting this waveform, suppose you see this waveform, a patient presents to you and you see this form of waveform, then what is the first thing you should ask? Have you done technically correct ultrasound? This is the first thing which you should ask. Number two, if technically you are correct, that is lowest pressure is applied, the free loop of cord is selected, there is no pressure over the cord, then if this is what is happening, it means it means that it means that the blood flow to the vessels is decreased. Okay. Yeah, I'm very happy that students are getting up this concept very clearly, and this is what I want. I want to simplify this Doppler, simplify this tough concepts of ultrasound so that it becomes very easy for you all to understand. Okay, I'm very happy to hear messages from you. Thank you, thank you. So this becomes very clean, very easy to understand. Right now, let's move ahead with this. So This is where we move from high class to low class. That is, as we move higher, sir, I have seen REDV type of waveform in dorsalis pedis and Doppler. It means the blood flow got reduced. Reversal of end diastolic waveform in dorsalis pedis Doppler. Okay. Dr. Rashmi, when it comes to, see, this is a beautiful question, but I would like to take it up, although it's out of context of our lecture. But see, this is an important concept. It is related to lecture today, so I'll be discussing this. See, this is the normal waveform what you get in limb. Okay. Sometimes this third waveform might not be seen, and you can get such waveform. Looks like biphasic. This can also be seen in lower limb. So in dorsalis pedis, ideally you should get this waveform, and sometimes you get biphasic waveform. So both of this waveform, they should not be confused that there is a reversal of end diastolic flow in lower limb. Why? Because in lower limb, there is something which is called Wind-Kessel effect. What is Wind-Kessel effect? That during systole, this goes down, and then during diastole, there is a recoil which happens. So what happens is, systole mein there is blood, diastole mein the blood flow goes down, and then there is a recoil which happens. As a result, you see the third wave, positive wave. Okay, that is because of Wind-Kessel effect. Okay, the further recoil which takes place. Now, so this triphasic waveform or this biphasic waveform, which looks as if there is reversal of end diastolic flow, is normal for lower limb. For lower limb, it is normal. Okay, but if you see this in uterus, it is abnormal. Okay, that is what I was talking about. But suppose if you start saying monophasic flow in lower limb, then this is abnormal. So monophasic flow for lower limb is abnormal. Okay, chalo. Now let's move to this categories and classes. So if you see here, initially you have the PI which is low, and you see that there is continuous diastolic flow. This is the normal part when the PI is low and there is a normal continuous diastolic flow. Now what happens is the PI starts on getting increased, and still the continuous flow is there. This is class 1. Then you see that the end diastolic flow almost reaches the baseline. There is decrease in diastolic flow. Then you see that in further, as the class moves up, you see the end diastolic flow is absent, and then as it moves up, the end diastolic flow is completely reversed. Okay, so these are the various categories which we have seen. Now, the few important Doppler tracing areas which you should know. Whatever area you want, that should be zoomed so that you get a better picture of that area. Okay. Next is applying the color box. So the color box has to be applied such that, suppose this is the part to be examined, it should be zoomed as much as possible. And then you should apply the color box. The color box should be as small as possible. You should narrow down the color box. Then the next important thing which you should take care of is the scale. I showed you that there is a scale which is there in the side. So suppose if you are examining for arteries, then you want to keep the scale higher. Similarly, if you are looking for veins, then you want to keep the scale lower. Okay. Now, similarly, the other important basic techniques when we apply to pulse wave gate is, gate should be such that it covers up the vessel. Then you have to adjust the scale and adjust the filter properly. Now let's come to the technical part. Okay, for the technical part. So PSV. What is PSV? Peak systolic velocity. That is the peak, means the highest velocity during systole is called PSV. And there are utilities of PSV. So one, we have seen that it is used for calculation of S by D. We have seen, just now I explained you what is S by D, PSV upon EDV. Similarly, I also told you that it is used for calculation of PI and RI. I'll show you the formulas. Okay. Now, out of this, if I ask you the question, PSV, S by D, PI, RI, which is the best parameter? which is the best parameter. If I want a single parameter for Doppler, which is the one which you would select out of this? So very good. The one which you would select out of this is, yeah, people are confused between PI versus RI. So which is better? Is it PI or RI? Is it PI or RI? So correct answer is PI, pulsatility index. So PI is the best measure of hemodynamic information. Okay. Now look here. So now here you can clearly see. What are you able to see? This is the fetal head, right? So whenever you want to start the Doppler study, you always start it with, never you start it with Doppler. You always start taking basic measurements. Okay. You should never forget taking basic measurements. So you have to take all the growth parameters. You have to measure BPD. You have to measure the head circumference. Then you have to measure the abdominal circumference. And remember, why is abdominal circumference very important? Because this is the first circumference which gets affected out of all the four important parameters what we measure in patients with FGR. Okay. So we measure for abdominal circumference. Okay. Abdominal circumference is measured from outer to outer. BPD is measured from outer to inner. Hmm? And head circumference is measured from outer to outer. And then the fourth important parameter which we use is FL. So after you finish with this, you move towards the bladder. So this is urinary bladder, what you are seeing here. This is urinary bladder. This is the femur. And we have focused here on femur. So see how we have filled the screen with the thing which we have to measure. We have decreased the gain. And the length which we measure when measuring the femoral length is the diaphysial length. This spur is excluded from measurement. The metaphyseal spur is not included when you measure for FL. Okay. So once you measure the FL, then out of these four parameters, what you get is the estimated fetal age. And you also get AGA or average gestational age. And you get estimated fetal weight, that is EFW. Now, so this is the report which you would get like this. And now look here very carefully. If you see, by gestational age, okay, she was coming out to 35 weeks 3 days. But by ultrasound, she has came to just 32 weeks some days, 4 days. Now, if you see here and compare BPD, HC, ACFL, you see that the AC is the lowest one, because this is the parameter which gets affected earliest and maximum. And if you see, these are the percentiles. These are the percentiles. So if you look here, this percentile, this is less than 5 percentile at BPD. This is less than 10 percentile. This is again less than 10 percentile. If you see the estimated fetal weight, which is 1931 plus minus 299, here this is again less than 10 percentile. If it is less than 10th percentile, what does this mean? Yes, I want you all to tell. What does this mean? If it is less than 10 percentile, will you call it IUGR? Directly you will call it IUGR? Then what's the importance of Doppler? So always remember, less than 10 percentile is SGA. Okay. So less than 10 percentile is SGA. Very good. So few of you have given correct answers. Yes. So less than 10 percentile is SGA. But suppose if you get less than 10 percentile, baby, with Doppler changes, now this is FGR. Okay, now this is FGR. Similarly, if you get less than third percentile, now suppose you get EFW which is less than third percentile, then this is directly FGR. Remember that if you get less than third percentile, this is direct FGR. You don't wait for the Doppler changes to occur. Okay. So hope you have enjoyed today's session. Okay. I briefed you about the basics of Doppler, and we talked a bit on FGR, SGA, etc. And very basics. I also covered about the waveforms and all. And inshallah, in my next lecture, we shall be talking more about this, and I'll be elaborating further about the techniques, and we'll talk more continuing these concepts. Okay.